now. Is he here? No? Okay, I thought he was in the room. Yeah. Another powerful presentation. For those who were not here yesterday, he spoke in depth about his company, Billard Real Estate. They have an exhibition behind us that you can catch up with them and see the opportunities there for investing in property in Nigeria. Okay, so we are going to move on to our next panel discussion. Before we do, I just wanted to quote something that Professor Pat Utomi said. He said, the role that the diaspora, we have an instrumental, I'm paraphrasing, role in the revival of Africa. In the revival of Africa. And he spoke about India, China, and how their diaspora were instrumental in the rising of those nations. And when I think about those places like China and India, and seeing how they are essentially really global powers now, it makes me excited that we are doing this today and others elsewhere to match, if not exceed, the growth and potential of Africa. So thank you once again for getting us excited about the continent and all the opportunities. So I'd like to invite our panel guests. For those of you who are a little bit hungry, we do have lunch coming up next. And we'll hear more from the likes of Professor Pat Utomi after lunch on a panel. But next, we are going to actually be just talking about one of the areas for significant opportunity. We heard a bit about it yesterday. We're going to go into more depth today, and we will be looking at access to affordable healthcare and health insurance specifically in Africa. You heard the Africa Diaspora Corporation chairman speak this morning about insurance. This is your opportunity to ask questions, to dive a bit deeper, understanding how you can get involved and how that can transform the healthcare industry across the continent. So please, can I invite Dr. Terence L. Baker once again? So Dr. Terence L. Baker, we heard from him yesterday, another energetic presentation. He is CEO and president of Solid Medical Center. He also has 144 beds, I understand, across Kenya. So already investing in the continent in phenomenal ways. May I also invite Dr. Chief Emeka Kalu. Is he in the room? He is the president and CEO of ECK Foundation. I know he was with us yesterday. Is Dr. Kalu here? Not yet? No? Okay. We'll go to the next person. It's Dr. Sylvester Eje, Director of Investment, African Diaspora Corporation. Please, can you take the panel? Thank you. And lastly, but not least, of course, Dr. Amobi Ezenekwe, Director of Contact and Mobilization for African Diaspora Corporation. Thank you, sir. You can have two on one side and one on the other side. Actually, we'll do it differently from yesterday. So if you sit over here and I'll sit here, yeah, I've made you all. Thank you, Mr. DJ. Welcome. Okay, we'll get straight into it. So we are going to open it up to the floor, but I'll just start with a few questions. Thank you again, sirs, for being here today. So, early healthcare. I see a signal. I've had to flex a lot today. My mind is on overdrive. Yeah. My apologies, thank you. Okay, we'll continue. Early healthcare. So we heard a little bit about it before and how that can prevent many issues we see at the moment across the continent if we intervene a bit earlier. How can we drive early healthcare across Africa and prevent critical, expensive diagnosis that often leads to sometimes death unnecessarily? I'm going to pass it over to you. Can we have another mic actually? So let's make it easy. Thank you.
Hello. So your question, to paraphrase your question, is how can early intervention prevent expensive overdiagnosis and expensive healthcare? Okay. So this is
Sorry, so how can we drive earlier intervention? How can we encourage people across the continent to intervene in their health earlier? So what can the diaspora do to encourage that?
So the diaspora, as you're aware, that's the reason why we started this initiative, because we have about 7 of the board members are physicians or people in the healthcare profession across the globe. So we are very passionate about healthcare. We are very passionate about early intervention, and we know in medicine we have done a very, very good job in terms of diagnosis, but we've not done a very good job in terms of treatment. What I mean by that is that if you can diagnose any disease, it's extremely easy to treat the disease. So what are we saying? That the ADC, we are partnering with some of the primary healthcare providers, some of the insurance companies in Nigeria, we're trying to reach to all the insurance companies. We signed an agreement with Venus, or we had a conversation with Venus. We're supposed to sign some kind of an agreement yesterday. So the importance of prevention and emphasis on the people that actually provide the healthcare services. Think about children, mothers. Mothers are the primary people that is, when they know when their kids are sick and they know when to intervene. So getting healthcare innovation at that very, very early stage is probably the best way for us to reach out to most people, because the vast majority of the diseases that kill people in Africa are preventable diseases. We've talked about diarrhea disease, we've talked about malaria, we've talked about upper respiratory tract infection. We actually just went through pandemic, and we saw how a simple respiratory infection could have wiped the entire continent out. And thank God that we were able to actually develop a vaccine that was able to prevent that. So partnering with various agencies that will drive immunization and all the primary preventive care measures is actually the way to have the most impact. And that is where ADC is focusing our initial strength, because we'll have the most impact by doing that.
Thank you, sir. And can you just to follow up on that, some people in the room are encouraged and they want to get involved. Can you talk to us a little bit about how this will look? Is it a subscription? How you've got an app? I understand yesterday you mentioned. How will this work? How, if I want to protect my family in Nigeria with insurance, are we going to sort of follow the blueprint of how it's done, say, in the US or the UK? Or is there something that's best suited for Nigeria that ADC is working on? Please explain.
Yeah, healthcare is every healthcare module you look at is going to be different. Every healthcare you look at is going to be the model we operate in the United States is different from the model of healthcare they operate here in UK, and it's probably different from the model of healthcare we operate in other African countries like Kenya. So the way we plan to approach this is again is through partnership with the local providers. We talked about subscription-based healthcare. You know, the healthcare is never free. There's going to be the dual involvement of the government and the private sector. And the only thing we can control at this point is the private sector involvement in the healthcare. So the private sector is going to be through some kind of subscription. Like I said, private insurance. We all have private insurance in the United States. Most people have private insurance. Some of the people that cannot afford private insurance, the government comes in to subsidize those care. So currently our main effort, our focus is primarily based on providing affordable insurance. And the key word is affordable because, you know, you can spend in, I work in the area of cancer and diagnostic medicine.
That is to see the kind of plan Venus had for Nigerians. I'll give you a good example. My chief and I, who were looking at that, about a baby in the incubator, it has a limit to how many days the baby has to be there. Why? You do that for 1 week and you throw the baby out? So there's no emphasis on education. My chief and I were talking about emergency medical services, CPR, common education for the signs of stroke, signs of a heart attack. What do you do when this happens? These are things we teach our kids in the United States. I tell you that my 17 years old son in his school, while in middle school, already learned about CPR.
So are you suggesting in education of experts or education of the populations?
Population, early education of the population. They have to be aware. Healthcare, one thing about healthcare is two factors: the provider and the patients. If you're aware that you have to go and see a doctor and have a yearly checkup, say for a woman, yearly mammogram. If you're not aware of that, how can you do that? If you're not aware that at the age of 45, you should get your colonoscopy, how can you do that? If you're not aware that for males in your 30s, at least somebody must have done a digital record examination to look at your prostate, how can you do that if you're not aware? So the most important thing to drive this down to our people at home is early education, and that is incorporated in what we're doing. Aside from providing the care with insurance that we're providing, we're also going to drive early education.
Thank you, Dr. Edge. At this point, I'm going to do something a little bit different before you continue, Dr. Baker, because awareness largely is, the media is king of building awareness. And I know we have from Ingenja Media, Mazi. I'd actually want to invite you to join the panel just for a second. We're going to change things up a little bit. If you don't mind, if we can just invite you to join the panel and bring another perspective to this, because you're saying something very important. Thank you. You're saying something very important, and you're also the Director of Contact and Mobilization. How do we build this awareness, and how can Diaspora help to transfer that knowledge, build the awareness, potentially using the media? You are an expert in mobilization, I understand. Can you speak to that, please?
Well, okay. Yeah, I've just moved from someone who's sat there listening to speaking now. You threw me off balance. Anyway, I think I would talk from personal experience. Njenje Media, for instance, I'll start from what Njenje Media is and what it does. It's an online platform, predominantly TV, engaging where the conventional media sometimes don't cover. Now, that is where the diaspora, in terms of using media to mobilize. I started off as a student who went to Germany to study. Eventually, from studying in Germany, moved to UK, live in the UK and have a family here. But, engaging in Nigeria and mobilizing in Nigeria is like a drug. You cannot live outside Nigeria without constantly going back at someone who is on drug. And at some point, you're hooked in. And that mobilization became apparent in last year's election. For real, you can see that, not belittling those in Nigeria, but the media vibe that you saw in Nigeria last year happened as a result of diaspora engagement. Diaspora funded it, and diaspora were more vocal. Even now that the election has finished, you can see that a lot of individuals are struggling now because we are sliding into Bacha era. But you can also see that the Nigerian diasporas are still using the new media to stand up for their kit and kin back home. So speaking to the question as to the using the media to mobilize, I believe that the diaspora do have a very, very large voice, because most times, you know what pounds or dollars is in the exchange market. You have something that you use in influencing people, because before now, you can see that someone is given 2 cups of rice to go certain way. But most of the people in the diaspora mobilize using their finances to change that someone whom you pay their school fees, pay probably their house rent, or eventually buy insurance for. It is much easier to, obviously, they say who pays the piper dictates the tune, right? So if you're doing all this, telling that individual, not out of malice, but to say, I have been in this part of the world. I have seen that I do not need spiritual intervention to have electricity, and I don't need to speak in tongues to iron my clothes, and I don't need to, shout up NEPA, down NEPA to really get my phone charged. Then when you say certain things, it's out of exposure. And that constant engagement, be it through the structured channel as media, or be it through one-on-one conversation, changes narrative and helps people to also mobilize for greater good. Thank you.
Thank you so much. And I do apologize for throwing you on the spot there, but you did a fantastic job responding. I mean, I want to talk about, I mentioned I work for the BBC, and we have a small organization called BBC Media Action, where you might be familiar with them, yeah. So we actually create content, especially around healthcare, and distribute it across the continent and other regions as well, to educate about really basic things like sanitation. And it helps. We focus on remote areas, remote villages, to educate about things that perhaps are not being spoken about, and maybe in areas where there's not a lot of education. So I totally hear you on this, and I think this is something that perhaps the diaspora wants to get more involved in, even just by word of mouth. And I'm actually going to go to you now. Dr. Terence, did you want to comment on that specifically? Yeah.
Yes. As a physician who actually operates a hospital in Kenya, I can tell you that education is where it's all about. Now, the question that was asked is very specific. What can the diaspora do? What can all of you do? And what can the diaspora do? Tomorrow morning, you can start an advertising campaign on TV, radio, news media, all very receptive, as the BCC is, all very receptive to stories. For example, in Kenya, the World Health Organization recently started a vaccination program against malaria for the children around the bodies of water. Not well known. I mean, our organization has published several newsletters about the success of that vaccination program, but again, it's a lack of knowing. Mothers can't take their children to get vaccinated if they don't know. So we have the news media, number one, educate, educate, educate. The diaspora can be in front of the news media on a regular basis. The diaspora, particularly from Nigeria, Kenya, South Africa, are some of the most powerful men and women in Africa. And so you have the ability to educate, educate, educate. Number two is vaccinate, vaccinate, vaccinate. When there are vaccines available for well-known disease, and I understand since HIV, there's a suspicion about vaccinations. We saw that suspicion during COVID-19. Many Africans chose not to take the vaccine because they were concerned that there was something hidden inside of it that would change them forever. And I understand that reluctance. I had it too. And I'm not an African. But vaccinate, vaccinate, vaccinate is so important. Number three is understand that the church and the schools are a tremendous way to get the word out, and it's virtually free. That is, you can go to the Minister of Health, the Minister of Education, and you can talk to them about putting together campaigns to talk about common waterborne disease, common parasites, common upper respiratory tract diseases, tuberculosis, HIV transmission from mothers to newborn infants. These are all treatable problems. HIV transmission to young babies can virtually be eliminated in a very short period of time if we just educate the mothers as to how the disease is getting transmitted from them to their newborn babies. It's just an education. Modesta Vasander, who's the CEO of Kitani Hospital, she just did a doctorate in public health. She just did a paper that will be coming out to all of Africa to talk about these risk factors for the transmission of HIV to newborn infants. And so what am I trying to say? Don't forget your schools. Don't forget your Minister of Education. Don't forget your Minister of Public Health. Use the resources they have, your churches, your schools. Get the word out and education. We could probably decrease communicable diseases and non-communicable diseases caused by the environment by a third in the next 5 years if we would just educate our patients, our people.
Thank you. Education is key. And just to follow up from that point, actually, you know, I worked a lot in the media landscape in West Africa. What's the other one? Is it AIM? There's another big one. And actually, you mentioned Lebanon recently. They're owned by a big Lebanese family in Nigeria. But the point I'm making, those are quite big, but the local radio stations, where actually the population is wide, very cheap to advertise. You can get their contact details on a Facebook, and you've reached 1 million people. You know, and I don't want to say what it would cost to undercut them, but it's very, very affordable. Whilst we are on you, do you want to?
Yes, I need to add to what Dr. Baker had said. Professor Toby just talked about government being the problem. I think in Nigeria, the impact of government being the problem is even more than we talked about. I was looking at some numbers this morning that in Nigeria, the percentage of GDP that is spent on healthcare is only 3%. There is so little you can do with spending 3% of your gross domestic products to provide healthcare to 250 million people. Look at a country as wealthy as the United States. We spend about 17 to 18% of our GDP on healthcare, and about 29% of our budget on healthcare. Out of that, the total spending in the United States, the government spends about 46% of that, and the private sector spends about 54% of that. So this is the only way you can have a balanced healthcare, because healthcare is not cheap and it should not be free. There needs to be collaboration between the government and the private sector to make sure that affordable healthcare is.
Because we're talking about the diaspora insurance supporting their families back home. What impact will that have on the infrastructure? Sometimes there's this risk that if we are pouring in remittances, whether it's for healthcare or whatever it might be for, does that not take the onus off of government to now invest in infrastructure, because we are the ones that are investing? So how can we ensure that whilst there is that support from the diaspora, it is also positively impacting the infrastructure across the continent?
Yeah, and the chairman said that this conversation is not about Nigeria, but Nigeria represents about 20% of the whole population of Africa. So if you can change the situation of healthcare in Nigeria, you're more likely to have most impact in the entire health system in Africa. So to answer your question, everything about healthcare infrastructure has to be a joint relationship between the government and the private sector. The ADC, NDF cannot build a hospital system without working through the government sector to make sure that the system provides all the subsidies and all the things that is needed to make that system effective. Many of us here have put in hundreds of thousands of dollars in some fashion in building or investing back into the society. I give you an example. I set up 10 years ago, I started investing in diagnostic medicine. I set up CT scan, all the diagnostic, ultrasound, name it all the high-end, diagnostic equipment in Nigeria. But what happens with all this infrastructure is that we did not get the buy-in from the government to support the operation of these equipment. And eventually what is going to happen is that you get to the point that you're looking for staff, you're trying to partner with a government establishment, they either want a kickback from you or they frustrate you so much because they think that you're going to be a competitor to the government establishment. So at the end of it, you get frustrated about all these efforts to provide affordable care to the people. So I think the answer to your question is, yes, you can put in as much capital into setting up the infrastructure in Nigeria, but you need to work with the government so that you can optimize the functionalities of that investment.
Thank you. And I was going to go over to you, actually, Dr. Baker. Can you speak a bit to what you have done in Kenya in response to that? Because, of course, I'm assuming you must have worked with the government in some capacity in Kenya to establish what you have done, so.
Good follow-up question. And I would add to my colleagues here the understanding that, as we learned yesterday, you blessed me with the opportunity to present, 65% or more of all common disease in Nigeria and the other 53, 54 nations of the African continent can be treated with a small budget and can be treated locally. It doesn't require advanced technology of ultrasound and CAT scans and MRIs. We're talking about 65% of the common diseases. For example, yesterday we talked about over 2,000 children in Nigeria will die today between the ages of 0 and 5 years of age. They're not dying because they need a CAT scan and an MRI. They're dying because they need water, they need some IV fluids, they need some oxygen, they need antibiotics. They just need a warm place to get out of the weather for a little time. And they'll live because Africans are very durable. We're all very durable. And so they just need a little help. And so fortunately, the infrastructure to start with, and for example, there's a group that the Nigerians, you should know about it. It's an organization called Nigerian pharmacists trained outside of the United States or outside of Africa. That organization is over 3,000 board-certified pharmacists who have returned back to Nigeria. Foreign-trained pharmacists. They're meeting in October at the Sheraton in Lagos. If you have time, stop by. But why do I mention that? Well, there's 3,000 pharmacists who trained outside of Nigeria who have chosen to return home. What's the cost of that? It's nothing. They're operating pharmacies, working in pharmacies, over 3,000. Now, what do we know about a pharmacy? Pharmacies are associated with 1 or 2 community physicians in general. Even your remote pharmacies, your remote chemists have 1 or 2 physicians or nurses associated with them. What's the budget for that? Very little, because those networks already exist. Also, the pharmacists, these Nigerian pharmacists who have returned home, they are certifying their medications. So you get rid of this fake medication problem that is plaguing Nigeria and all the other nations, including Kenya. So fake medications, that is, a patient goes and gets some care, but then the medication they get will never treat them because it's not medication. A lot of times it's just junk. Finally is, again, it comes back to your basic education often will allow early intervention, which doesn't require a hospital setting or any serious infrastructure. Yeah, it's true that 25-30% of all the diseases being faced by Nigerians and Kenyans and South Africans and the other 53 nations do require advanced technology. But we can take care, think about it, wrap your minds around this, 65% or more of the common illnesses that are present in your nations today, the African nations, can be treated with a very limited infrastructure. Also, never minimize digital examinations and artificial intelligence. I believe that artificial intelligence and digital examinations, telehealth, can also go a long ways towards putting a telehealth site in virtually every church, every school, every pharmacy.
Thank you, Dr. Baker. I just want to go over to, thank you, that was very, you want to add to that? And whilst you have the mic, I actually also want to answer your question really quickly whilst you added to that. Yesterday, Dr. Baker mentioned that 5%, I think you're speaking about Nigerians, have healthcare. And, you know, ADC have this ambition to increase that, I'm assuming through health insurance. So can you talk to us a little bit about your growth plans? How are you planning to grow? At what rate? And how do you want to increase the number of Nigerians with healthcare through the diaspora?
Okay, well, before I get to that, let me add a little bit on this infrastructure and the diaspora involvement. If you look at the West, the Western healthcare system, we have large healthcare systems that actually own hospitals. These large healthcare systems are the ones that put up either the big-scale hospitals in the bigger cities, and then in the rural areas, they put up small 50-bed, 60-bed hospitals that funnel into the main hospitals. That's the way the system is run in the West. Governments get involved in some little county hospitals and all that. But in Nigeria, it's a different problem. We have a three-tier system where you have the primary healthcare centers funneled into general hospitals now called the federal medical centers. And that funnels into the teaching hospitals. Back in the day when I trained in Nigeria, the teaching hospitals were the epic of healthcare centers in Nigeria. But now, the same teaching hospitals don't even have the facilities needed for anything. So, from my knowledge, I know that some diasporans have tried to chip in to bridge this little gap, but not at a pace that's fast enough to meet the demand. And also, the concentration of these healthcare centers that have been put up by diasporans is not well equitably distributed. So everything is set out in Lagos. For instance, the Nigerian case, it's there in Lagos and Abuja. You don't have the rural areas. And those who live in the rural areas have difficulty traveling to access these high-quality healthcare in all these areas. So, diasporans, we have a role to play in this. Instead of focusing our attention on where there's a high yield profit in what we're doing, we can also extend this things out of the goodness of our hearts to rural areas and make sure that those areas also have simple things like ultrasounds and facilities that they can use, not the big MRI scans or CT scans. Not every rural hospital in the US has MRI and CT scans, so we can do that. Now, to your next question about the health insurance at 5% individuals, yes, it's quite appalling that the Baker told us yesterday that only about less than 5% of individuals, have some kind of health insurance to pay for their care. About 70% is out of pocket expenses. In fact, that's what we looked into as an organization, and that generated our interest in Venus Healthcare. I've had the privilege as well of being involved with a number of state health insurance schemes, which I dealt with in 2021, trying to register about 100 something individuals from my village, based on our charity organizations that we carry out to help patients. So from that experience, I realized that what the insurance companies are actually providing for the release is really nothing. So when we heard about the Venice Medicare, we brought and we analyzed what they were offering Nigerians and felt that it's also very skeletal. So we decided to customize our own health insurance, our own outlook of the whole health insurance scheme that they were trying to offer. These are the benefits. These are what we want to mirror what we have in the United States. Basically, we use the United States model to do that. So if we succeed with this, we're going to sign that MOU with Venice. Bet you a whole lot of diasporans will buy into it, because why? The premium is so cheap when you convert that to foreign currency. So we hope to project this and have this spread all over, and this will help to some degree.
And sorry to check, do you have numbers? Is there a plan? Do we have a...
It's going to be hard to place a number where there's nothing to start with. Basically, at this point, less than 5% of individuals have healthcare. So we hope at least to push that needle, to push that bar to probably, let's say, 15, 20, 25%. You know, it has to be exponential growth if we need to succeed. But in a market that you don't live in, you know, it can't really put a finger and say, this is how we're going to take it.
Let's stick with 50%. If we want to get to 50% coverage, right? Let's stick with that. The media, mobilizing. What can we do? What can the ADC do? This is free consultation now, to accelerate that growth and ensure that the African diaspora everywhere, and this will probably be the last question, understand that this is an opportunity, to something that's available to transform the healthcare of their loved ones back home.
Thank you very much. I think on this, you know, what the ADC is doing is like lighting up a candle. Now, that's where the media comes in. You can't light up a candle and put it under the desk. It's not going to see the light of the day. So that's constant media engagement. You know, like when you were speaking, you talked about how cheap it is to run ads or jingle. I mean, in most of the local stations, you can get a jingle for 3,000 naira for 1 minute. So, you know, aggregate that. It's not that much big of a money that some people in the, you know, in the diaspora can actually do. You know, so, and there are also other areas. For instance, I wanted to ask him a follow-up question when he talked about partnership. I'm glad you're from Anambra State, right? Now, in 2007, when you talk about the diaspora working with the locals, I personally imported ultrasound machines, I think Ayoka, it was called, from Germany then, into the community hospitals in my village, in my community, with a couple of Zimmer frames and wheelchair. Now, how do you then handle that? Understanding that 2 years later, I came back, none of those machines were working, none of those wheelchairs, the wheels are blown up or gone up. So how do you deal with that? Now, finally, you know, in wrapping up with my own question, I think the key to what ADC needs to do to get out there is media engagement, constant media engagement across the spectrum. Thank you very much.
Thank you. Would you ask?
Yes, well, both of us shared some experience. So, so I've sent a whole bunch of equipment from our hospital to home, EKG machines and all that stuff, only to go home and find them all dust covered everywhere. So now I learned from my chairman here, Dr. Kafo. He has a First Care Foundation. So he's got an organization that is going to donate equipment to the hospital that his foundation built in his hometown. So that some of those equipment are high-level biomedical equipment that need to be serviced. So he did a smart thing because I'm going through this route. So I asked him, what did you do? How did you convince these guys to send all this ultrasound and stuff to you? He said he liaised with Nanda's Teaching Hospital. So that's the key. You have to liaise with a higher service center that have people in the biochemical engineers that can service equipment. That's the key to it. And that's what I'm going to do with next equipment we're going to send home. And that's what he plans to do as well. Thank you.
Thank you so much, Dr. Eje, Dr. Baker, Dr. Ezenekwe.
Yeah, can I
am about to close. You want to close? I've been given warning.
Yeah.
I am scared on this stage.
To add to what Dr. Eje had said, that you know, it's not hard to operate an ultrasound machine. It's not hard. You know, I'm a diagnosis, I'm into diagnostic medicine, and we can do all the high-end, you know, modern medicine. The bottom line is that you can train a non-medical person to do to run a basic diagnostic equipment. The challenge is always when that machine breaks down. How do you fix it? How do you timely fix it? Not just fixing it, but how do you fix it so you do not compromise the health of the people? So what some of us have done is, if you have the resources to buy some of the cheaper equipment in multiples, just like an ultrasound machine or portable ultrasound, we have facilities in the United States that can get some of this equipment used, and you're paying about 10% of this equipment. And by so doing, if one breaks down, you continue to provide services until you deal with the problem of fixing, because in the United States, it might take you just a phone call, but in Nigeria, it might take you a month to even find someone that can come and take a look at that equipment.
So I wonder if there's something to do about standard and institute, standard authority. So is there, I don't know how it works in Nigeria or any African country, to be honest, when it comes to healthcare. When there's accountability, so if someone is doing an inspection and you fail as a hospital, that then ensures that you have to have a maintenance culture because everything has to be top-notch quality. Does that exist? And is that something that can be established so we can reassure the diaspora that when you do send things over, there is compliance and things that have to be followed to ensure that your investment is safe?
You're looking at a 20 container doctor. I've sent over 20 containers from a company in Virginia Beach, and I won't ever do it again. Now, here's the word for the diaspora and any of you that are going to be investing in equipment. Find a supplier in your country and buy it from them, because in Kenya, and I believe also in Nigeria, if I ship in containers of high-end equipment, oftentimes parts are not available, and the local service companies that do exist have no motivation to service that equipment because you didn't buy it from them. You want them to come in on the cheap and fix it, but they're not very motivated to do that. So, Dr. Fori, I have to tell you, Modesta and I have decided we're not shipping anymore. We're not going to ship container number 21. We're not. It might be okay for beds and IV poles and simple things, but it's not okay for equipment, high-end equipment that does need service. We bought our laboratory from a local GE supplier in Kenya, and guess what? No problems at all. They service it on a regular basis. It's very economical.
Thank you, Dr. Baker. Thank you.
Yes.
Understood. So point noted, collaborate with the locals. Collaborate with the locals to protect your goods. Well, once again, Mazzy, thank you so much. On the spot, like a pro, but you are in media, so this should be easy to you. Dr. Baker, Dr. Ezenekwe, Dr. Eje, thank you all very much. Can we get a round of applause? We are now going to be going to lunch. After lunch, we have our final panel, after lunch, and we will hear again on that panel from Professor. Because things are always changing. We'll hear again from that panel from Professor Pat Lutomi, Dr. Abdullahi. Is he here? Was here earlier? Okay. Deacon Iyoboye, Chief Jonathan Anebe, and Dr. Eje, and they'll be talking specifically about generally investment in Africa. So please have your lunch, enjoy. Please do return to engage in that panel, ask your questions. I actually did not ask questions from the guests, and I promised I would. So after lunch, we will ask you to contribute to that discussion. So please do return timely. I think we have, how long do we have for lunch? 1 hour. What time is it now? I've got my watch on me. 40 minutes. Okay, we have about 40 minutes. So we can return at 4 o'clock, I'm assuming. Is it 4 or 5? 4 o'clock, okay. Yeah. So DJ, please do keep us giddy with some music whilst we eat. Thank you.